Thank you, Dr. Juwairia, for the kind introduction. So my name is Maryam and Saeed. I'm an endocrinologist practicing here in Dubai at Mediclinic City Hospital and Mediclinic Dubai Mall. I'm also an assistant professor of medicine at the Mohammed bin Rashid University here in Dubai, part of Dubai Health. So we'll start today with a story of obesity in the UAE. And as this is a regional talk, many of you, I understand some have actually joined us from other countries, neighboring countries, but the majority of you practicing here practice within the UAE. So we'll start with some of the background of what's going on here. These are my disclosures. So I'll start with an image of the UAE. So this is Dubai, and you see the Sheikh Rashid Tower, which is part of the World Trade Center. And this picture was taken in the late 70s, when it was new. And this is a similar angle just recently, maybe a couple of years ago. And visually, to many of us who live here, we see the changes visually in the environment. We see the changes in the way of life. We see the changes in movement with different workload, with different navigation through our daily life, and the difference in foods, the availability of ultra-processed foods, the availability of delivery services. And really, when we look at the external changes, superficially, we really need to understand what are the other changes that have occurred with this dramatic shift over a period of 30 to 40 years. So what are some of the changes that have happened to our health as a result of this change of way of life? So some of the learning objectives for today was really to look at what is obesity, why is it a concern, and to explore the epidemiology of obesity and some of its metabolic complications here in the UAE. So there's a lot of definitions for obesity, and I've chosen to highlight the one from the World Health Organization, the WHO, and what it uses is, so we may use the BMI definition, the body mass index, which is a kind of a rough guide. Now, it's not accurate in everyone, especially if you have a muscular build, but in general, for most individuals, you could probably use a BMI cutoff, and that's probably what we use in our clinics. So overweight, having a BMI more than 25, and obesity over 30. However, the important part of the definition of obesity, which I want you to focus on, is it's not just excess fat. It's not just excess adipose tissue. It's abnormal excess fat that can impair health. So is excess fat on its own abnormal, or is the nature of that fat abnormal? So that's the question we're trying to answer. And it is really relevant when it can impair health. So it doesn't matter what the BMI is. So you could have individuals with a BMI of 25 or 27 that have abnormal fat that is impairing their health in some way. And you could potentially have somebody who has a BMI of 30 who has not yet reached that level. So this is an important distinction. The prevalence of obesity, you can see the dark navy areas. Those are areas that are close to 30% or more in terms of the prevalence of overweight or obesity. And look at the area here in the Middle East, the Gulf region specifically, even Egypt and the UAE, and similar areas would be probably the United States. Okay, so we have some things in common, and you can see how that can be of a concern to us specifically. Focusing in on the UAE specifically, so this was data from 2019 on adults in the UAE, and we can see, so the gray part is the number of individuals who have overweight, and the blue is obese, so BMI more than 30. And you could see that if you want to combine them among men and women in adults, they're actually quite close to 60%, the combination of the two. And you can find that overall men have more total overweight with obesity, but women in this region have more obesity. So what should we expect going forward? When we look at those images, we look at the prevalence, how prevalent it is in our region, how is it going to be going forward with further changes? So from the World Obesity Federation, so they estimated that by 2060, there's going to be around 30 or 33 countries around the world that have more than 88% of their population, both adults and children, living with overweight or obesity. And in children, we'd probably define that as having a BMI more than the 95th percentile for their age group. And 88% is a huge number. 11 of those 30 countries are actually in the Middle East. So a third of that growth is going to be in our region. Fortunately, the UAE is not in this list. However, it's not far off. It's not 88%, but it's about 82%. So I'm not sure if we can consider that a success in our trajectory if we continue the way we are now. So looking at our trajectory specifically here in the UAE, so if you want to combine overweight and obesity together, in males and females, so that's where we're at now. So we're close to, we're more than 70%, between 70 and 75% among men and women. And if you want to look at obesity on its own, we are here, men about 30% and women close to 40%. And the trajectory going to 2060, we're just over 80% there, close to 82%. So this is a concern, okay? And if I can tell you that this data is comparing 2020 to 2060. But if we want to go back to 1975 in the UAE, and what was the overweight and obesity rate then, it was close to about 10%. So it's a huge difference for a very relatively short time frame. And why should we be concerned? So does it matter if you carry extra weight? So we're aware of several complications that could be associated, and I've divided them into category by the pathophysiology really, into metabolic complications, mainly related to dysfunction from the abnormal fat, which I'll talk about next. The mechanical complications, for example, weight-bearing joints, knee pain, back pain, sleep apnea, and maybe edema and other things that could occur because of the extra weight, as well as the psychosocial factors, reduced quality of life, depression. You could see the metabolic complications of obesity. It's a pretty long list of conditions, and the question is, why are they grouped together? Why do we have fatty liver disease with dyslipidemia, with hypertension, with dysglycemia, cardiovascular disease, PCOS, all together? And are these different conditions, or is there a common connection between all of them? Very good. So we have the answer there. So to start with, if you want to look at the adipocytes, so as per the definition of abnormal excess fat that impairs health, if we look at adipocytes in lean adipose tissue, so in normal individuals who don't have overweight or obesity or don't carry the genes that are making them prone to insulin resistance, so you'll find that they use mainly oxidative phosphorylation. So this is the internal process within the cells to maintain equilibrium. But if you look at the hypertrophic adipose tissues, when you gain weight, you get hypertrophy of the adipose tissue. You would have an inflammatory response. So you would have possibly if it's really extreme necrosis of the fat, there's not enough blood supply, potentially there's necrosis, there could be macrophages coming in. There are changes within the cells that switch the anti-inflammatory M2 macrophage into pro-inflammatory M1 macrophage. You have cytokines, pro-inflammatory factors coming in, and you find that the immune cells mainly use glycolysis to produce these cytokines, really leading to a pro-inflammatory state, not only within these adipose cells, but also across the whole system. So if I look at Jeffrey Mechanic's theory or suggestion of categorizing this by the ABCD method, which is, when is obesity a disease? So when is it a disease, or is it a disease on its own, and should we just stick with obesity? What should we look at in terms of its complications? So obesity is a chronic disease, but again, there are stages, as with any disease. So as with heart failure, as with diabetes, as with cancers. So it can be progressive, it can have more severe complications, less severe, and it's a spectrum, really, that varies from an individual. So you can start with the abnormal adipose cells, and with the inflammatory reaction that could occur. Again, there are genetic factors that contribute to this in addition to the excess fat. And you'd have insulin resistance developing with this pro-inflammatory state and the presence of adipokines, which can lead to hyperinsulinemia, which would lead actually to hyperinsulinemia. And eventually you would develop the metabolic syndrome. This is where you get hyperglycemia, so maybe something like pre-diabetes initially, and then it develops into diabetes. You could get hypertension, dyslipidemia, and eventually type 2 diabetes. Cardiovascular disease follows the same path as well. They're interconnected. And then once you live with these conditions, and if they're not really controlled, you will get the complications associated with this disease. So it's really a spectrum of disorders that build up at a cellular level with influence from genetics, influence from the environment, influence from lifestyle, and you put it all together and you get complications. So another way, apart from the ABCD system, which was suggested by Jeffrey Mechanic and his colleagues, is from Arya Sharma, so the Edmonton obesity staging system, which also follows a similar way of categorizing individuals with overweight or obesity as having either like a stage 0 or more progressive stage 4. And it's really based on the presence of comorbidities, of metabolic complications, and the severity of those complications, as well as end organ damage. So at the end, you get end organ damage. So really, it's a systemic disease. And it's interconnected. So now that we understand why obesity is a concern, what it could do to us, what it could do to our patients, what's happening here in the UAE? So what data do we have on the prevalence of all of these complications and metabolic diseases in our own patient population? So I'll start with the UAE Healthy Future study, which is still ongoing. So it's a cross-sectional study, really looking. They're hoping to get 20,000 individuals. So far, they've had questionnaires and blood pressure measurements, blood analysis done on about a little over 5,000 individuals. What I want you to note is the age group. These are young people, so between age 18 and 40 years, really young people in the UAE. And about 62% of the individuals who participated in this study so far have been male. And if you look at the prevalence overall of obesity in this young group of adults, 26.5% had obesity. Dysglycemia, which can be defined as either pre-diabetes or diabetes, was about 11.7%. Dyslipidemia really high at 62.7%. In this young patient cohort. Hypertension in 22%, And central obesity, which we know is associated with visceral adiposity and metabolic disease, was present in 22.5%. So it's really concerning to see that young people have these cardiometabolic risk factors here in the UAE. Another study, which is a little bit older, it was done between 2009 and 2015 in Abu Dhabi, so the AD Salama study, Abu Dhabi screening program for cardiovascular risk markers. So they looked at 1,000 participants, again, a cross-sectional survey. They had young individuals as well as older, so between ages of 20 and 79 years. And these participants did not have a confirmed diagnosis of any ischemic heart disease, cardiovascular disease, or diabetes at baseline. So they just wanted to check for their risk factors, their cardiometabolic risk factors. And nearly 85% of the sample had at least one or more of cardiovascular risk factors. Again, part of this group, it includes a young cohort. And if you want, they used multiple risk factor calculators, so Framingham was the main one. And 7.1% of this group had a high 10-year risk of cardiovascular disease. Again, if we want to look at the details, 18% had hypertension, 26% were smokers, specifically among the male group. And I mean, this is a modifiable risk factor. So I mean, you have a combination of modifiable risk factors and maybe some that are not so modifiable, they could be genetic. And overweight or obese, so they group them together, both together, 66.8%. So we're looking at, a combination of non-HDL cholesterol more than 130 milligrams per deciliter and 55%. A third study, also from Abu Dhabi, so they've been very active, and I'm glad that Dr. Mahmoud and Dr. Hani, they are here today, because a lot of these studies in Abu Dhabi really showed us what's going on, what's happening in our patient population and how we're doing. The Wiqaya is also an older study that was done between 2009 and 2010 roughly, and they looked at 50,000 individuals. And they found adults, and they found that obesity was present in about close to 32% of men and 38% of women. And overall, this was 35% of the population. Overweight in about 32%. Again, high prevalence of central adiposity, dyslipidemia in 44%. Pre-diabetes in 27% and diabetes in 17.6%. So a collection, you can see all these conditions happening together, prevalent together in the same patient population, because we know that it's the same driver for all these conditions, and you're finding similar values for all of this population. Moving on to Dubai, so a lot of that data was from Abu Dhabi, but if you move on to Dubai and look at the prevalence of diabetes, in a newer study that was from 2019, the Dubai Household Survey, and they looked at individuals who had known diabetes. In the green, these are Emirati nationals, so UAE citizens, and in the blue were expatriates living in the UAE. And you can see the known diagnosis of diabetes was 16% in UAE nationals. So 16% of adults, Emiratis, have diabetes, type 2. And it was about 10.5% in the expatriate group. And if you look at the total diabetes, some were newly diagnosed, so only during the study they found out that they had diabetes. And so if you want to look at the total, it's 19.3% of Emiratis with known type 2 diabetes and 12.4% of expatriates living in Dubai. And they found a strong association with the weight. So those with obesity were more likely to have diabetes. Again, that makes sense when you look at the way that diabetes and metabolic disease develops in general. Interestingly, it's not shown on the graph, but what about pre-diabetes? So this is only type 2 diabetes. How many of these individuals actually have pre-diabetes, which is also a risk factor, and it's a path to diabetes. So 12% of the adult UAE nationals had prediabetes. Interestingly, 17% of the expatriates. So it was a little bit reversed. The expatriates had more pre-diabetes and less diabetes, and the UAE nationals reversed. But overall, as a group altogether, it was highly prevalent, and it's one of the highest rates worldwide. So if we have all these individuals living with pre-diabetes or diabetes, how is it controlled? Are we doing a good job giving them medications, controlling their sugar, monitoring their sugar? Well, this was a study, this was actually done a while back between 2012 and 2016. So, we looked at more than 26,000 patients from across Dubai Health, so the Dubai government hospitals, both primary care and tertiary care centers. And we looked at how well they controlled their HbA1c over this period of 5 years. And was it improving or was it staying the same? And were we meeting targets? So we used the American Diabetes Association target of having the HbA1c below 7%. So that's our goal. If we were doing a good job, our patients would be less than 7%. And we found that unfortunately only 37.7% of our patients were achieving that, which means the vast majority had the HbA1c higher than 7%. And you can see these are in the dark blue. These were the individuals who were achieving HbA1c. The vast majority in the lighter blue there had HbA1c between 7 to 9%. So it's 8%, could have been 8.5%. And then there's even a subgroup who had it more than 9%. If we want to compare against other countries, so maybe everybody's like us, maybe it's not us, maybe it's the entire world facing the same problems. So if you look at this meta-analysis by Kunti, and more than 350,000 individuals from 20 countries, when they looked at how many of them were achieving the HbA1c below 7%, it was about 42.8%. So the whole world wasn't doing great, but we were a little bit worse, okay? So we were not achieving it. Now you could say that, I mean, when the time this study was done, it ended in 2016, so we did not have the prevalent drugs that were used at that time were probably DPP-4 inhibitors, with metformin, with sulfonylureas, and maybe it was related, but towards the end we did have some SGLT2 inhibitors coming in, and maybe some GLP-1, but maybe we could theorize, we don't know, maybe they were not utilized as much as we were utilizing it now. So we'll see later on how we're doing now. Fatty liver disease, again, this was a study from 2017 looking, I'll just focus on the bar here, which is looking at the overall prevalence. So different stages of fibrosis and liver disease, and just in the red you have more advanced stages of fibrosis. So you can see the number of individuals in the UAE who had fatty liver disease, and this is a trajectory, a projection for 2030, which they did in 2017 based on this data and based on what we estimated is going to happen with obesity rates. And you could see how this is going to be a problem with metabolic disease in general across all specialties. So if we have metabolic disease, high prevalence of risk factors, high prevalence of diabetes, even in younger individuals, what are the outcomes? So what's actually happening? So if we want to stage cardiovascular disease or metabolic disease into, complications and end organ damage, how are we doing? This is the Gulf Care study, heart failure study, which was actually done in 2015, and it covered 5,000 individuals across different countries. So Kuwait, Saudi Arabia, Qatar, UAE participated as well. It was a multi-center study, and they looked at acute admissions with heart failure to the emergency department. And the reason I have this as one of the outcomes was, for me as an endocrinologist, the interesting aspect of this was, if you look at the blue graph here at the top, this is the average age of the individuals who came in with acute heart failure to the emergency department. Here on the left is the Gulf Care study, which included the UAE, the Gulf states, and this is comparing it against other similar studies in Europe and in North America and in other countries, okay? So if you want to look at us, we're here on the far left. So the age was much younger. So look at the average age of our patients who are coming in with acute heart failure. They were at least 10 years younger than the rest of the world when they were presenting. So at least 10 years younger. So average age close to 60 years, and it was average of 70 for Europe and the US. And the second point I wanted to focus on was diabetes. How many of them had a comorbidity of type 2 diabetes? And you could see the red square, so the red graph there. We had more patients with diabetes compared to the rest of the world. So if we want to look at the demographic, who is our patient group who's coming in with these acute complications, you'd find that 50% of our patients have diabetes, how it's a contributor to this condition, and they're younger, which is not surprising when you look at all that data from the cardiometabolic risk assessment. I added in lipoprotein A, again, Dr. Hani, Dr. Wael, they worked on this. Again, lipoprotein A is genetically determined. It's a risk factor for atherosclerotic cardiovascular disease, which unfortunately, at this moment in time, we can't really modify. So I probably categorize it, for any cardiologists here, but I probably categorize it as currently a risk factor that is not modifiable, even with the use of statins, even with lifestyle changes. So it's genetically determined, and if we know that we had so many potential modifiable risk factors in our population here in the UAE, we also know that we have a lot of unmodifiable factors, so we can't change our genetics, unfortunately. We may carry genetics that are making us prone to insulin resistance. We have the genes that are making us prone to get hypertension, but we also have 1 in 6 patients who were tested for lipoprotein A had an elevated level. Again, that's just another risk factor. And 1/3 of these patients had tested, had cardiovascular disease. So that's just another thing to add to why we're facing this onslaught. So not surprisingly, if you want to look with all what we know so far about what's prevalent in the UAE, if you want to look at the UAE mortality data from the WHO, by far the #1 cause of death here in our country is ischemic heart disease. So 42.6% is related to ischemic heart disease. Again, what is #2? Stroke. So 20.4. Then there's kidney diseases. Then there's diabetes, hypertension, and maybe only here there's the COPD and road injury. I know the roads are, the topic of debate and with traffic, but road injury is 8.9, and then it's lower respiratory tract infections. So the leading cause of death is ischemic heart disease by far, and it's followed by an entire list of metabolic disorders. We are not surprised when we look at the epidemiology. And the disability-adjusted life years, now this study published in The Lancet, what is disability-adjusted life years? It's a calculation that combines mortality data, expected mortality with expected morbidity due to a certain disease. So let's say if you have individuals who have diabetes, then the question is, how much is that going to potentially cut their years from their life? And how is that going to potentially impact the quality of their remaining lifetime? So if you combine that together, it's called the Disability-Adjusted Life Year Score. And this is actually for all of the Middle East area. UAE is among them. So for example, this the one in blue is looking at the body mass index and how it's going to affect. There's LDL, there's hypertension. And if you want to compare from the past around 30 years, our disability-adjusted life years have worsened due to non-communicable diseases. It used to be communicable diseases, so we've shifted to non-communicable diseases, such as these chronic metabolic disorders. So it's increased by more than 275% in that time frame. So we have that data on what's going on regionally. The question is, we'll touch on this in the talks that are coming up, how much weight should we lose if we want to avoid all of this? So if we went back to the root cause, which is the excess fat that is abnormally functioning, leading to this pro-inflammatory state and insulin resistance and all the cardiometabolic disease leading to death eventually and poor quality of life, how much should we lose? There are many studies, a combination of data from lifestyle intervention studies, which unfortunately did not do so well, but there was an impact of lifestyle intervention studies, especially reversal of pre-diabetes, and it remains an important factor to look at, especially in preventive health programs. And if we look at the bariatric surgery studies, such as the Swedish obese subject study, when we saw what weight loss did in the long term, and the direct study, again, which was a lifestyle study where they cut down on the caloric intake of individuals, a range of between 5 to 15% weight loss was giving different benefits. But if you want to reverse diabetes, if you're talking about diabetes remission, you're probably looking at a figure closer to 15% in terms of weight loss. Maybe for some of the other metabolic diseases, you could have less weight loss, but close to 15% is probably for diabetes remission and improved mortality. We have the data on mortality from the bariatric cohort. The challenge we're probably aware of is there's so many contributors to obesity. As I highlighted, just the obesogenic environment that we're living in, apart from genetics, apart from psychosocial factors, so many contributors, which makes this a true challenge. And if we look at the guidelines, so what do the guidelines currently recommend? So the American Diabetes Association and European Association for Study of Diabetes in 2022, they updated their guidelines, and I'm focusing on diabetes here, not just because I'm an endocrinologist, because we saw how its insulin resistance and also the presence of diabetes as a comorbidity was closely associated with the development of cardiovascular disease and other metabolic disorders here. And how, later on, we'll learn some of the diabetes medications started to take a role in not only managing diabetes, but also managing obesity and overweight. So if we want to look at the guidelines, what was new was that they divided the choice of medications that you would go for and the targets for management in your patients by really, does this patient have increased atherosclerotic cardiovascular disease risk? Now, you could argue anyone with type 2 diabetes has increased risk, whether they have developed it now or not, but whether it's present and they have uncontrolled, say, dyslipidemia or something else going on, and then whether they have heart failure, whether they have kidney disease. So again, you have to factor that in and consider medication that has shown proven benefit in reducing these complications. And on the right, what was unique was the addition of weight as a target. So weight is a target on its own, apart from having these complications. It's a little bit too late if you're waiting for complications to take action. So why don't you go on earlier on in the disease process to act on the weight before you get all of this, as well as the glycemic efficacy? So the changes were equal weightage for cardiorenal risk and glycemic and weight management, equal weight, equal risk. The prominent focus that was given to weight management, the drugs that were recommended, GLP-1 receptor agonists or SGLT2 receptor inhibitors as first line, independent of metformin, and GLP-1 receptor agonists specifically if there is atherosclerotic cardiovascular disease. So they are mentioning if the individuals are at high or very high risk. I spoke to you earlier that many individuals have 1 or 2 risk factors. Technically, they're all high risk, but these are for the individuals who have more than 1 risk factor. I will end with a study before we move on to our next speaker to see where we're at now. So we saw how by 2016, most of our patients with diabetes were not meeting HbA1c targets.
So more than 60 to 70% had the HbA1c more than 7%. This study, the PACT-MEA study, looked at individuals, patients from multiple countries in the Middle East and Africa region. It included more than 500 patients from the UAE. There was a total of more than 3,000 patients with type 2 diabetes across 55 different sites in both primary care and secondary care. And what they found was the overall prevalence of atherosclerotic cardiovascular disease in these individuals was about 21%. So when you're seeing your patients with type 2 diabetes in clinic and you're thinking, well, does this patient have atherosclerotic cardiovascular disease risk, or should I think of certain medications for them? You would know that a very high percentage of them would have probably established cardiovascular disease. They already have it established. They do have end organ damage. And by country, if we want to look at the UAE, the prevalence was more than, so overall as a group it was 21%, but in the UAE specifically it was 30%. 30% of our patients with type 2 diabetes have established atherosclerotic cardiovascular disease. They already reached the end stages. We're not even talking about those who are on the way there. So how were we treating them? Were we doing a good job? Were we following the guidelines when we have this group of patients? What happened to those 30% of people with such a high risk profile? So again, the number is very similar. Remember I showed you the data from 2016? Between 2012 and 2016, so only 37% of our patients were meeting the target of HbA1c below 7%. And now we see it's still 37% only meeting the target, even with the advent of new medications. So why is that? Because look at the new medications that we have. So only 13% of this group were using GLP-1 receptor agonists. So despite the evidence that we have now for its benefit in atherosclerotic cardiovascular disease, only 13% were using GLP-1. 37% only were using SGLT2 inhibitors. And again, if you want to look at the other risk factors like blood pressure, so every time I see a patient in clinic, I have a checklist of things I want to make sure they're meeting. Is the blood pressure on target? Is the LDL or non-HDL on target? Is the weight being managed? Are they compliant with their drugs? Is the glucose managed? So we have this checklist, and we're not meeting the target. So only 30% were meeting the blood pressure targets of below 130/80. Only 30% had an LDL-C below 70. Again, these are people with established disease. And only 16% were exercising, or at least they claimed they exercised. And 15% had a normal BMI of below 25. And again, just as a reminder, I've used the BMI 25. It's a multi-ethnic cohort, but if we want to look at the majority of Emirati nationals and individuals from South Asia who dominate the demographic group here in the UAE, the BMI of 25 is even high for them. So it should be even lower than that. So if we wanted to revise the BMI cutoff, we'd end up with even far higher values of prevalence of overweight and obesity. So to conclude the PACT-MEA study, so 21% overall, but 30% in the UAE of patients with type 2 diabetes had established disease. 99% of these patients have very high risk, okay, and only a small number of them were using GLP-1 agonists or SGLT2 receptor inhibitors. So in summary, obesity is a major contributor to morbidity and mortality. Regionally, it's expected to increase in prevalence over the upcoming years, unfortunately. Cardiometabolic disease is a spectrum of interconnected disorders. It contributes to the pathophysiology of multiple organ system disorders, affecting the heart, affecting the liver, affecting the brain. It is both genetically determined and influenced by weight. Medical strategies in the investigation and management of cardiometabolic disease can be optimized. We'll hear more of that later on in the sessions based on the current evidence base.